You know, millions of us take medication for our hearts, but what are those little pills actually doing? Well, today we're going to decode them, and you'll be pretty surprised to find out that one of the biggest risks is something your dentist is probably the most clued in on.
All right, let's just start with a really stark fact. Cardiovascular disease is not just some common issue. It is the #1 leading cause of death in the United States, period.
So because of that, millions and millions of people are taking pills every single day to manage it. But do we really get what those pills are doing inside our bodies? I mean, how exactly do they work to control something as powerful as our cardiovascular system?
Okay, so here's our game plan for today. We're going to break it all down. First, we'll look at the heart of the problem. Then, we'll simplify things with a really cool analogy, your body's plumbing system. After that, we'll peek inside a pharmacist's toolbox, figure out how to read a prescription, and then, we'll get to that surprising dental connection.
All right, to really wrap our heads around how these complex drugs work, we need a simple way to think about it. So, let's picture your cardiovascular system not as some big medical mystery, but more like a really sophisticated piece of engineering.
So just think of your cardiovascular system as this intricate, high-pressure plumbing network. It's basically a closed-loop system, and its whole job is to pump blood to every single part of your body. And in this system, your heart. That's the powerful pump at the center of it all. And your blood vessels, your arteries and veins, those are all the pipes. The whole thing is designed to handle a ton of pressure, 24/7.
So what exactly is high blood pressure or hypertension? Well, if we stick with our plumbing analogy, it really boils down to one of three problems. Either there's just too much fluid, too much blood in the pipes, or the pipes themselves are too narrow, which creates a lot of resistance. Or number three, the pump is just working way too hard. Okay, so if those are the problems, how do we fix them? Well, let's open up the pharmacist's toolbox. You can think of every medication as a very specific tool, designed for a very specific job.
Right, so if the problem is too much fluid in the pipes, the first tool you'd reach for is a diuretic. You've probably heard them called water pills, and that's pretty much what they do. They help your body flush out extra salt and water. Less fluid means less pressure. It's really that simple.
Okay, but what if the pump itself is working overtime? Well, for that problem, you've got beta blockers. These drugs basically go to the heart and tell it to, just chill out a bit. They slow it down, reduce the force of its pumping, and boom, that lowers the pressure in the whole system.
And for that last problem, the pipes being too narrow, you need something to relax and widen them, right? That's where a whole bunch of different drugs come in, like ACE inhibitors and ARBs. Their job is to tell the blood vessels to relax, which gives the blood more space to move through. More space means less resistance, and that means lower pressure.
Now, here's where it gets really cool. You actually don't need to be a pharmacist to figure out what tool does what. There's kind of this secret language hidden right there on your prescription bottle that tells you exactly how a drug works.
Yeah, the secret is all in the suffix, the ending of the drug's name. A lot of these drug families share a common ending. It's like a secret code, and once you crack it, you can instantly know what kind of job that medicine is designed to do.
So check this out. This chart kind of breaks down the code for us. Take beta blockers, the pump regulators we talked about. They almost always end in OLOL. The little memory trick here is that the L and O kind of look like a little B for blocker. Or how about ACE inhibitors? They end in PRIL. Just think PRIL rhymes with drill, and you buy a drill at an ACE hardware store. And for ARBs, it's Sartan. Just by knowing these little endings, you suddenly know a ton about what your medication is for.
Okay, but you might be thinking, why does this matter to me? That's my doctor's job. Well, this little bit of knowledge becomes super important in a place you would probably never expect, and that's the dentist chair.
I'm sure you've been there, right? Filling out those forms at the dentist, and there's that question, are you taking any beta blockers? It might seem totally random, but trust me, there is a very specific and very important reason they have to ask that.
And the answer has everything to do with a potential chemical interaction. See, it's about a drug called epinephrine. It's often mixed into local anesthetics, the stuff they use to numb you up. Epinephrine is what's called a vasoconstrictor, which is just a fancy way of saying it narrows your blood vessels. They use it to keep the numbing medicine in one spot for longer.
Okay, to really get the risk here, we have to go just one level deeper on beta blockers. Turns out there are two kinds. You have selective ones, which mostly just work on the heart. But then you have non-selective ones. And these guys, they block receptors in the heart and in other places, like your lungs.
So here it is. This is the critical moment.
What happens when someone who is taking one of those non-selective beta blockers gets a shot of numbing medicine that has epinephrine in it?
Well, that combination can set off a really dangerous chain reaction. Because the beta blocker is doing its job, blocking certain receptors, the epinephrine acts, well, unopposed. It causes blood pressure to spike, like way up. And then the body freaks out and tries to fix it by overcorrecting. And that can cause a sudden, sharp, and pretty dangerous drop in your heart rate and your blood pressure.
And it's that second part, that sudden drop, that's the really scary part. The technical term for it is reflex bradycardia. And that right there is exactly what your dentist is trained to prevent.
And that brings us right back to the beginning. That one little question on the dentist's form isn't just them being nosy. It is a critical safety check. It's the perfect example of why knowing not just that you take a heart pill, but knowing what kind of pill it is so important. It lets you be a real partner in your own healthcare.
So let's end on this thought. The next time you pick up your prescription bottle, take a second and look at the name. See if you can crack the code. Because knowing what's on your medication list, it isn't just a fun fact. It could literally be life-saving. So I'll leave you with this question. Do you know what's on your list?
All right, today we're going to dive into a pretty amazing world, the one that's happening inside our own bodies completely on autopilot. We're going to pull back the curtain and see how modern medicine has figured out how to hack this secret operating system. And trust me, by the end of this, you're going to get it too.
So, let's start with a question. Have you ever really thought about this? How does an asthma inhaler know exactly where to go? It seems kind of like magic, right? How can a drug be so precise? Well, stick with me because you are about to find out exactly how it works. So, meet your body's unsung hero. This system is working for you 24/7, managing literally thousands of different things that keep you alive, and you don't have to think about a single one of them. It's what's making your heart beat right now, what's helping you digest your lunch, all of it, totally automatic.
And this incredible system, it has a name. It's called the Autonomic Nervous System, or the ANS for short. You can think of it like the ultimate background app on your phone. It's always running, constantly making these tiny little adjustments to keep your body in perfect balance.
And really, the key thing to get here is that the ANS is the master controller for everything we don't consciously do. It's the whole reason you don't have to sit there and remind yourself, okay, breathe in, now breathe out, okay, heart, beat, now. It's just automatic. The name says it all.
So how does the ANS keep everything so perfectly balanced? Well, it's not actually just one system. A better way to think about it is like two opposing forces, constantly locked in this delicate biological tug of war for control of your body.
On one side of the rope, you've got the parasympathetic system. We'll call it PANS. Its job is summed up perfectly by its nickname, rest and digest. And pulling on the other side is the sympathetic system, or SANS, which you've definitely heard of. It's our famous fight-or-flight response. One calms you down, the other one gets you all amped up.
And here's the key difference. The PANS system is all about quiet, everyday functions, so its actions are really specific, kind of localized. But the SANS? Well, that's like pulling the fire alarm. It triggers a massive, system-wide alert to get your whole body ready to face a threat, whether that's a bear in the woods or just a stressful exam.
Okay, so if these two systems are always trying to stay in balance, how do drugs fit into this? Well, they're basically a way to hack the system. They artificially tip the scales one way or the other. So first, let's look at how we can mess with the rest and digest side.
The first tool in our little hacking toolkit is a class of drugs called cholinergics. What these do is they basically boost the natural signals of the PANS system. Think of it like putting your foot on the rest and digest gas pedal.
Now, a really easy, if not slightly gross way to remember what happens when you hit that PANS accelerator is the acronym SLUD. It stands for increased salivation, lacrimation, which is just a fancy word for tears, urination, and defecation. See a pattern? It's all about ramping up the body's fluids and waste removal systems. And here's a perfect real-world example. There's a drug called pilocarpine. It's often given to people who suffer from severe dry mouth. It's a cholinergic, so it directly targets the S in our SLUD acronym, telling the body, hey, make more saliva. It's a simple and really effective little hack.
Okay, so we know how to press the gas. But what if we want to do the exact opposite? Well, for that, we use drugs called anticholinergics. These guys are blockers. They literally get in the way and stop the PANS signals from getting where they need to go. They're like hitting the brakes on rest and digest. And just like we had SLUD, we've got another great little memory trick for this one. A, B, C, D. Anticholinergic drugs are pretty famous for causing blurred vision, constipation, and dry mouth. It makes perfect sense, right? If you're blocking all those rest and digest functions, everything just dries up and slows right down.
And here is a fantastic example of where a side effect becomes the main effect. You know that D for dry mouth in our ABCD mnemonic? Well, that's exactly what a dentist wants before they start working in your mouth. So they'll often give patients a drug called atropine, which is an anticholinergic specifically to cause that drying effect. Pretty clever, right?
All right, we've figured out how to hack the rest and digest system. Let's flip the coin and look at the other side. What happens when we want to artificially trigger that fight or flight response? This is where things get really cool and a lot more targeted.
I absolutely love this quote because it makes a really complex idea so simple. The fight or flight system doesn't just have one big on switch. Instead, it has different types of switches, or receptors, for different jobs, just like Toyota makes different car models for different kinds of drivers.
So here are the 3 main models you need to know about. You've got alpha-1 receptors, which are mainly on your blood vessels. Hitting them makes the vessels squeeze tight. Then you have beta-1 receptors. They're on the heart, and the way to remember this is easy. You have one heart. And finally, beta-2 receptors. They're in the lungs, and you have 2 lungs. Stimulating them makes your airways open up. And this brings us right back to that question we started with. An albuterol inhaler is what we call a selective drug. It's designed to talk almost exclusively to those beta-2 receptors in your lungs, telling them to relax and open wide. It mostly ignores the beta-1 receptors in the heart, and that's why it can rescue your breathing without making your heart go totally crazy. It's not magic at all. It's just incredibly targeted hacking.
Okay, so we've seen how these drugs work by either hitting the gas or the brakes on one of our body's 2 major automatic systems. But what about that long list of side effects you always see on the medicine bottle? Where do they come from?
This right here is maybe the biggest takeaway from this whole thing. Side effects aren't a mistake. They're not a bug in the system. They're actually a feature. They are the logical, totally expected result of how the drug works. When you take a drug to intentionally cause dry mouth, you're activating a system that also happens to cause constipation and blurred vision. The side effects are just the other things on that system's to-do list.
So, I'll leave you with this little challenge. Now that you know about PANS and SANS, about SLUD and ABCD, and about the different receptors, you basically have the decoder key. The next time you look at a medicine label and read the side effects, ask yourself, okay, which system is this thing hacking? Is it activating fight or flight, or is it blocking rest and digest? You might just be surprised at what you can figure out all on your own.
You know the feeling. A pounding headache, a sprained ankle, that sudden, awful toothache. So you pop a pill, and like magic, the pain starts to fade. But have you ever really stopped to think about what's going on in there? How in the world does that little pill know exactly where the ouch is and how to shut it down? I mean, whether it's the stuff you buy at the grocery store or something stronger from a doctor, these are some of the most common medicines on the planet. But the way they work is actually this incredible journey through our own nervous system. So today, let's follow that signal and see what's really happening. Okay, first things first, we've got to understand what pain even is. And it's so much more than just a bad feeling. The best way to think about it is as your body's super sophisticated built-in alarm system. It's a message, and its whole purpose is to protect you. So how does that alarm get tripped? Well, it usually kicks off with something pretty straightforward, like an injury. The second your tissue gets damaged, a whole chemical chain reaction starts. And this is the beginning of the most common kind of pain we all feel, which has a specific name: nociceptive pain. Nociceptive pain is basically useful pain. It's the kind of pain that screams, "Hey, that stove is hot, you should probably move your hand." It has a very real, very important job to do, and it's all started by these tiny specialized sensors. And those sensors are called nociceptors. Just think of them as the microscopic tripwires for your body's alarm system. They're on guard 24/7, just waiting to detect anything that could be damaging. Too much heat, too much pressure, you name it. And when they do, boom, they fire off that pain signal. You've got these little guys woven all through your skin and tissues. They're like the frontline soldiers of your pain response. But here's where it gets really fascinating. The ouch that you and I feel, it's not actually one single thing. It's 2 completely separate events happening at almost the exact same time. That's right. Every single time you feel pain, you can actually break it down into two parts. There's the raw physical signal itself, and then there's how your brain decides to react to it. So on one hand, you have pain perception. This is the nuts and bolts electrical signal that travels from the injury through your body's wiring, what's called the peripheral nervous system. This is the fact of the pain, and it's pretty much the same for everybody. But then you have the pain reaction. This happens in the main command center, your brain and spinal cord, or the central nervous system. This is your personal, emotional, psychological response, and it's totally subjective. It's the reason you might barely notice a paper cut while your friend thinks it's the end of the world. And understanding this split is the absolute key to how all painkillers work. So let's start with the most common guys, the non-narcotics you can just grab off the shelf. Their whole strategy is to go after that first part of the pain equation, the perception. They try to deal with the raw signal itself. These drugs don't really care about your brain or how you're feeling about the pain. Nope. Think of them more like a local fire department that gets sent directly to the scene of the fire, the damaged tissue where that alarm bell is ringing. So here's the clever part. When your tissue gets damaged, it releases these chemicals that basically poke the nociceptors and make them scream. What these drugs do is they interfere with your body's ability to make those chemicals. So they don't completely silence the signal, but they do turn its volume way, way down. It's like putting a pillow over the alarm bell. Okay, so that's playbook number one. But what about the bigger guns, the prescription painkillers like opioids? Well, they use a completely different strategy. They're not interested in turning down the volume at all. Instead of heading out to the site of the injury, opioids bypass the local problem completely. They go straight for headquarters, your brain. Now, this is the most crucial part to get. When you take a narcotic, the pain signal from your injury still makes it to your brain. The fact of the pain is still there. But what these drugs do is hack your central nervous system and fundamentally change your reaction to that fact. They essentially tell your brain, yeah, we hear that alarm, but who cares? They can create a sense of detachment, even euphoria, so that the pain signal just doesn't bother you anymore. So, to boil it all down, non-narcotics are the local crew, working out on the periphery, right at the injury. Narcotics are the central command, working up in the brain. Two totally different strategies, targeting two totally different parts of that thing we call pain. Now, all this makes perfect sense when you've got an actual injury. But what happens when the pain isn't coming from damaged tissue at all? What if the body's alarm system itself is broken? And that question leads us to a whole other category of pain, one that millions of people with chronic conditions have to deal with every single day. It's called neuropathic pain. So, remember how we said nociceptive pain is useful? Well, neuropathic pain is the complete opposite. It's not a helpful warning signal. It's a malfunction. It's caused by damage to the nerves, the very wires of the alarm system. It's pain that serves absolutely no purpose. The fire alarm analogy is perfect here. It's like an alarm that just won't stop blaring, even though there's no fire, no smoke, nothing. The system that's supposed to report the problem is the problem. And as you can imagine, that's a much, much trickier thing to fix. And this is exactly why treating neuropathic pain requires a totally different toolbox. You can't just throw a standard painkiller at it. Instead, doctors often use drugs that were originally made for completely different things, like anti-epileptics or antidepressants. And why? Because those drugs are good at calming down overactive, misfiring nerves, which is exactly what's going on here. It's a way more complex challenge. I think this quote just sums it up perfectly. Normal pain is the messenger. Neuropathic pain is when the messenger itself has gone completely haywire. And at the end of the day, this is why all of this really matters. Understanding if your pain is a useful signal about an injury or if it's a malfunction in the system itself is the most important first step to getting relief. You just can't fix faulty wiring by taking the batteries out of the smoke detector. So let's recap one last time. Non-narcotics work low, down in the peripheral nervous system, out at the site of the injury. Narcotics work high, up in the central nervous system, changing our reaction in the brain. Two different strategies for the two parts of a single ouch. It really makes you wonder, doesn't it? Pain is this universal thing we all experience, but the mechanics behind it are so unbelievably intricate. It just begs the question, what other common things are our bodies doing every single day that we rarely, if ever, stop to truly understand? You know, when you take a pill, do you ever stop and think, how do we actually know this is safe? It's a question we totally take for granted now, right? But believe me, the story of how we got to this point is a wild ride. We're talking magic potions, some really tragic mistakes, and a scientific revolution that literally changed everything. Wow, just look at these. Elixirs, tonics, remedies. They look so quaint, don't they? Almost charming. But just over 100 years ago, this was your medicine cabinet. And let me tell you, it was the Wild West. You could walk into a store, buy a magic potion that promised to cure, well, anything, and have absolutely zero idea what you were actually putting into your body. And that's exactly where our story kicks off. Before 1906, there were basically no rules, no system, no one checking this stuff. It was all about flashy marketing and, unfortunately, very well-hidden ingredients. And what you didn't know? Well, it could literally kill you. And products like these were everywhere. I mean, on the left, you've got Mrs. Winslow's soothing syrup. Parents swore by this stuff for their teething babies. On the right, an ad for a new drink that's supposed to perk you right up when you're exhausted. They look totally innocent, right? Even helpful. But, let's pull back the curtain on what's inside. Okay, get ready for this. The secret soothing ingredient in that syrup for babies, it was morphine. Yeah, morphine. And as you can imagine, this unregulated so-called remedy was tragically linked to the deaths of infants. It was an absolute horrifying wake-up call that something had to change. And what about that popular tonic for the tired brain? Well, you've probably heard this one before. It was the original Coca-Cola, and its famous formula contained an extract from cocoa leaves. Yep, that means cocaine. It was sold as this miracle health beverage, but again, people had no idea what they were consuming. The complete lack of transparency was the real danger. So as you can guess, stories like these started coming out and people were furious. I mean, rightfully so. They demanded that someone, anyone, do something to protect them. And that public outrage is what finally forced the government to step in and say, okay, we need some rules. And this didn't just happen overnight, it was a process. First, in 1906, we got the Pure Food and Drug Act. This was huge. It basically said, hey, if you're going to put morphine in your product, you have to say so on the label. It was a start. Then, a few years later in 1914, the Harrison Narcotic Act came along and said, you know what? You can't just sell this stuff over the counter anymore. But the real game changer was in 1938. The Food, Drug, and Cosmetic Act finally gave the FDA the power to say, nope, you can't sell this until you prove it's actually safe. And that whole foundation led to the system we have now, which is kind of run by a team of 3 big agencies. You've got the FDA, they're the main gatekeepers, approving drugs and making sure they're safe. Then there's the FTC, which keeps an eye on advertising to make sure no one's making crazy, false claims. And finally, the DEA steps in to regulate any drugs that have the potential to be abused. So, okay, we have the rules. But what does a new drug actually have to go through to get to your pharmacy today? Well, let me tell you, it's not a walk in the park. It's more like an obstacle course, a really, really long and expensive one. It's a gauntlet of tests designed to prove 2 critical things: that a drug is safe and that it actually works. It all starts with what's called preclinical testing. This is all in the lab with cells and animals, just to see if the basic idea is sound and safe. If that goes well, we move on to people. Phase 1 is super small, like 20 to 80 healthy people, just to figure out a safe dosage. Phase 2 gets bigger, a few hundred people who actually have the condition to see if the drug even does anything. And if that looks good, we hit Phase 3. The big one. We're talking thousands of volunteers to really confirm everything. Safety, effectiveness, side effects, the whole shebang. A drug has to pass all of that just to get a chance at FDA approval. But wait, there's more. Even after a drug is approved, the job isn't done. There's a Phase 4, which is basically forever. It's called post-marketing surveillance, and it means the FDA keeps watching. Why? Well, you can test a drug on 3,000 people, but what happens when 3 times million people take it? Sometimes rare side effects only pop up then. It's exactly why drugs, like the painkiller Vioxx, sometimes get pulled from the market years after they're released. Okay, so all of that intense testing and regulation is why we have the labels and information we do today. But let's be honest, sometimes that stuff can be a little confusing. So let's crack the code and break down a few key terms you're going to see. First one you see all the time, generic name versus trade name. It's actually super simple. The generic name is the official scientific name of the drug. Think ibuprofen. There's only one of those. The trade name is just the brand name that a company gives it, like Advil or Motrin. Once a drug's patent runs out, lots of companies can make it, which is why you see multiple trade names for the same generic drug. So the big question is always, are generics just as good? And the FDA's answer is a big yes, because they have to meet this standard called bioequivalence. Now that sounds complicated, but all it really means is that the generic version has to prove it acts the exact same way in your body as the brand name one. Same stuff, same result.
All right, another thing you might hear about are drug schedules, Schedule 1, Schedule 2, and so on. This is a system from the DEA, and it's simply a way of ranking drugs based on how likely they are to be abused. Schedule 1 is the highest risk. Think heroin, stuff with no accepted medical use. And the numbers go down from there. Schedule 2 is high risk but has a medical use, like OxyContin. And it goes all the way down to Schedule 5, which has the lowest potential for abuse, like some cough syrups with codeine.
So, we've gone from magic potions to this incredibly complex system of rules and testing. But you know what? It all comes down to one person who's the most important part of this whole equation, and that's you. The entire system is built to keep you safe, but it can't work properly unless you're an active participant. Think about it. What is the absolute #1 job of any healthcare provider, whether it's your doctor, your dentist, or your hygienist? It's this, to do a complete and thorough health assessment. But here's the thing, they can't do that job without your help. And that means you have to tell them everything. I'm not just talking about prescription drugs. I mean every vitamin, every herbal supplement, everything you're taking. And you might think, why does my dentist need to know that? Well, some of those supplements can have serious interactions with local anesthetic. Some of your prescriptions might cause things like dry mouth, which is a huge deal for your oral health. Your provider needs the full picture, the whole story, to make the safest choices for you. So the next time you're sitting in that doctor's or dentist chair, just remember how far we've come, from mystery potions to modern medicine. This whole system we've been talking about is built on one crucial thing, transparency. Your medicine cabinet and everything in it tells a critical part of your health story. The only question is, are you ready to share it?
Imagine a pain so bad it feels like it's taking over your entire world. Now, what if there was a medicine that could just switch it off? And not only that, but it also brings this incredible wave of calm, maybe even happiness. That's the amazing promise of opioids. But what if that exact same medicine could also destroy your life? In this explainer, we're going to dig into this double-edged sword. What opioids are, how they actually work, and how they manage to become both a miracle and a total crisis.
It's a really fundamental question, right? Something we all have to face at some point. Think about a major car accident, or the recovery after a huge surgery, or, the final stages of a terminal illness. What can possibly stand up to that level of suffering? Well, for thousands of years, humanity has had one go-to answer.
Believe it or not, for centuries, we've relied on this one flower. We've been taking its milky sap and turning it into the most powerful pain medicines known to man. Then, back in the 1800s, scientists got really good at it. They isolated compounds like morphine and codeine, and suddenly, they unlocked a kind of pain relief that was completely unimaginable before.
So you go from this ancient flower to a sterile, mass-produced bottle of pills. In a way, that journey is this huge triumph for modern medicine. But it's also the backstory to a massive public health crisis that has just ripped families apart. So how did we get here? How did this miracle of science become the source of so much pain?
To really get a handle on the opioid crisis, we've got to start with the basics. We need to demystify what these drugs even are. So what are we talking about when we say opioid? And what exactly makes them so incredibly effective? And, of course, so incredibly dangerous? So opioid is kind of this big umbrella term. It covers the natural stuff from the poppy, like morphine, but it also includes all the synthetic lab-made drugs like oxycodone and, yes, fentanyl. The one thing they all have in common is how they work in our bodies. They all target these very specific landing spots or receptors in our nervous system.
And here's where they're completely different from other painkillers. Let's say you take an Advil for a headache. That medicine goes to work on the inflammation right at the source, right where it hurts. Opioids, they do something totally different. They basically bypass the problem area and go straight for the command center, your brain and spinal cord.
And this is a huge difference. Opioids don't actually heal your injury. They don't stop whatever is causing the pain. Instead, they act like they found a master switch in your brain, and they just turn the volume on those pain signals way, way down.
They don't fix the problem, they change how you feel about it. And that is an incredibly powerful effect.
And that brings us to the other sharper edge of the sword. Because once you start messing with your brain's chemistry to block pain, well, you end up setting off a whole cascade of other effects. Some of them are exactly what you want, and some of them are deeply, deeply dangerous.
I mean, on the one hand, what these drugs can do is just incredible. It's not just the powerful pain relief. They can also bring on this deep sense of calm, this wave of euphoria, a feeling of pure well-being. It's that potent 1-2 punch that makes them so effective and, frankly, so dangerously seductive.
But of course, that power comes at a price. Side effects like constipation are pretty common, but the real killer is something called respiratory depression. See, the same chemical process that numbs your pain can also slow down or even shut down the part of your brain that tells your body to breathe. In an overdose, that's what's fatal.
You know, our bodies are amazing at adapting. So when you use these drugs over and over, the brain starts to adjust. That first dose just doesn't hit the same way. That's called tolerance. And it's really the first step down a pretty slippery slope that forces people to take more and more just to get back to that initial feeling.
And this is where the trap really starts to snap shut. And get this, in as little as a week or two, your body can become physically dependent. It literally rewires itself to expect the drug to function, so when you take it away, the body just rebels with these agonizing withdrawal symptoms.
Okay, so now we have to talk about the really dark side of this story, how this personal struggle with dependence can explode into a massive public health crisis. To really grasp the scale of this tragedy, you have to understand the path from dependence to addiction and ultimately to overdose.
Okay, this is super important, and a lot of people mix these two things up. Physical dependence, that's just your body adapting to a chemical. Addiction, though, that's a disease of the brain. It's this compulsive, all-consuming need to get and use the drug, no matter how much it's destroying your life.
This quote just says it all, really. It captures the heartbreaking reality of addiction. For someone trapped in it, that initial feeling of euphoria, it's a distant memory. The drug is no longer about pleasure. It's about survival. Just taking enough to silence the agony of withdrawal so you can feel normal for a little while.
All right, now we need to talk about fentanyl. Fentanyl is basically poured gasoline on the fire of the opioid crisis. Look at this number, 2 milligrams. It's a tiny, almost invisible amount, but for most people, it's a fatal dose.
And this is what 2 milligrams of fentanyl actually looks like next to a penny. It's almost nothing. It's 100 times more potent than morphine, and because it's so cheap and powerful, it's being mixed into all sorts of other street drugs. A lot of the time, users have no clue it's even in what they're taking, until it's far too late.
The numbers, well, they tell a pretty terrifying story. In just 5 years, overdose deaths in the U.S. just skyrocketed. But here's the real kicker. Look at the role of fentanyl. The percentage of those deaths involving synthetic opioids like fentanyl jumped from less than a third to almost 90%. That's the fentanyl crisis, right there in those bars.
Okay, this is information that could genuinely save someone's life. There are 3 classic signs of an opioid overdose to look for. First, their pupils will become tiny, like the point of a pin. Second, they might become unconscious or totally unresponsive. And third, the most critical sign, their breathing will get super slow and shallow, or it might just stop altogether. But this isn't just a story about tragedy. There is hope. In the face of this crisis, science has given us some really powerful tools to fight back, to pull people back from the brink and help them find a real path to recovery.
Let me introduce you to naloxone. It's basically a miracle drug that can reverse an overdose in minutes. So think about it this way. If an opioid is like a key that gets stuck in a lock and causes the overdose, naloxone is like a master key that's way stronger. It swoops in, boots the opioid key out, and blocks the lock, stopping the overdose right in its tracks.
And the best part, this life-saving medicine comes in a super simple nasal spray that anyone can use. It's designed to be easy. Within minutes, it can completely reverse those deadly effects and bring someone back. It's an incredible tool.
And for people who are on that long road to recovery, there are treatments that could be a total lifeline. Things like methadone and buprenorphine help manage those awful cravings and withdrawal symptoms, and that gives people the stability they desperately need to start rebuilding their lives.
So at the end of the day, we're left with this huge, complicated challenge. Opioids are a gift. They can end unimaginable suffering. But they're also a curse that's caused so much pain and loss. The question for all of us, as patients, as doctors, as a society, is how do we find the wisdom to use this double-edged sword? How do we harness its power for good without being destroyed by it?
All right, let's jump right in. I want you to picture this. You're settling into the chair at the dental office, getting ready for a cleaning. The hygienist is super friendly, asks about your day, and then they get down to business with a question that seems almost, routine. But as we're about to see, that one simple question is actually the result of a whole century of medical drama, tragedy, and amazing scientific progress. So it all starts right here, with what feels like just another box to check on a form. But honestly, this question is one of the most important lines of defense for your safety. And not just in the dental chair, but pretty much any time you're talking to a healthcare provider. You've heard it a million times, right? Are you taking any medications, vitamins, or supplements? It's so easy to just rush through it. Maybe you forget about that daily multivitamin or that herbal tea you drink to help you sleep. But why are they so insistent on getting a full, totally honest answer? Well, this isn't just about paperwork. Not at all. Your answer directly affects how they plan your care. They're looking for potential side effects, like dry mouth, which can really impact your oral health. They're screening for dangerous interactions with things like anesthetics. They're trying to figure out your bleeding risk for certain procedures and putting these critical alerts right into your chart. Seriously, every single pill matters. And listen, when they say supplements, they mean everything. Vitamins, minerals, and especially herbal stuff. Things like ginseng or ginkgo biloba, which sound totally harmless, can have really powerful effects on your body, like increasing your risk of bleeding. And here's the key part. These products aren't regulated by the FDA with the same intensity as prescription drugs. That's exactly why your provider needs to know you're taking them. It's all about keeping you safe. So when you give them your list of medications, your hygienist kind of turns into a detective. Their whole mission is to piece together a complete puzzle of your health. And believe me, they have some incredibly powerful modern tools to help them do it. You can forget about the days of them flipping through some huge, dusty book. Nope. Now, they've got apps like Hippocrates right on their phone or tablet. This gives them instant access to a massive, always updated database of drug information. It's basically like having a pharmacist right in their pocket. With just a couple of taps, they can look up any drug you're on. They can double-check the dose, see what the common side effects are, and, this is a big one, look for something called a black box warning. That is the FDA's most serious type of warning, and it highlights potentially life-threatening risks that they absolutely need to know about before they do anything. And these tools are so sophisticated now. They can even help in really weird situations. Like, let's say a patient comes in with a loose pill they found in their bag and they have no clue what it is. The app can actually identify it just based on its shape, color, and the little markings on it. It's an incredible safety feature that helps make sure nothing ever gets missed. So we've got this amazing system now, right? Apps, databases, careful questions. But how did we even get here? Why is all this so necessary? Well, the answer lies in a past that looked very, very different from the pharmacy you see today. We're going to take a little trip back in time now, to the turn of the 20th century. This was basically the Wild West of medicine. It was an era of so-called miracle cures, magic potions, and absolutely zero regulation. Before 1906, literally anyone could bottle up some random concoction, slap a fancy label on it that says elixir or remedy, and sell it to the public with no oversight whatsoever. They could make any claim they wanted, and they never, ever had to tell you what was actually inside. And the secret ingredients, they were often just shocking. Popular soothing syrups for teething babies, they had morphine in them. Tonics that were supposed to help with exhaustion, and this includes the original formula for Coca-Cola, contained actual cocaine. And we're not talking tiny amounts. These were active, powerful, and super addictive drugs being sold right over the counter. I mean, just let that sink in. A product that was marketed to worried moms for their fussy, teething babies was essentially a narcotic. And tragically, these unregulated remedies led to the deaths of countless infants. It was these kinds of devastating stories that finally forced the government to step in and do something. And that action came bit by bit. It all started in 1906 with the Pure Food and Drug Act, which was a simple first step. It just said you had to list addictive ingredients on the label. Then came laws to regulate narcotics, and then a huge one in 1938 that gave the FDA real power over drug safety. Finally, in 1970, we got the controlled substance schedules that we still use today. This was a long, hard-fought battle for our safety. So what replaced that medical Wild West? Well, today, a new drug has to run this incredibly tough gauntlet of testing and oversight before it could ever possibly reach you. You've got three main agencies in charge. The FDA is the big one. They're the gatekeepers who approve drugs for safety and effectiveness. Then you've got the DEA, which handles any drugs that have a potential for abuse. And the FTC? They watch over all the drug advertising to make sure you're not seeing the modern version of a snake oil claim. The FDA's process is incredibly methodical. It starts in the lab with animal testing. If that looks good, it moves to human clinical trials. Phase 1 is a really small group of healthy people, just to check for safety. Phase 2 tests if it even works in patients with the disease. Phase 3 expands to thousands of patients to confirm everything. And guess what? It doesn't even stop there. Now, for drugs that could be abused, the DEA steps in and gives them a schedule. The logic is all based on risk. Schedule 1 drugs like heroin have the highest potential for abuse and no accepted medical use. And as you go down the list to Schedule V, the abuse risk gets lower and lower, and the rules for prescribing them get a little less strict. Okay, so a drug has made it through the gauntlet and gotten approved. The system's done its job, right? Not even close. In fact, this is where the most important person in the entire safety process comes in. And that person is you. Remember that last step I mentioned, Phase 4? This is what's called post-marketing surveillance. It's the ongoing safety check that happens after a drug is already on the market and being used by millions of people in the real world. This phase is so critical because it helps find rarer, long-term side effects that might not pop up even in a huge clinical trial. So how does Phase 4 even work? Well, it relies on people like you and your doctor reporting any unexpected problems. The FDA has a program called MedWatch, where literally anyone can report an adverse reaction to a drug. All of this real-world data is what keeps our medications safe long after they've been approved. Here's another really important idea for being an empowered patient. Labeled use is when a doctor prescribes a drug for the exact reason the FDA approved it. But sometimes doctors find that a drug works really well for something else. That's called off-label use. It's totally legal, and it's pretty common, but it's really good to know when it's happening so you can have a smart conversation about it with your provider. You see, it all comes down to a partnership. Your role is simple: full disclosure. Tell them everything, ask a ton of questions, and report any side effects. Their role is to take all that info, use their tools and their expertise to research it, and then plan a safe and effective treatment just for you. Safety really is a team sport. Which brings us all the way back to where we started. That simple question from the dental hygienist, it's not just a formality. It's your personal invitation to be an active partner in a safety system that's been over 100 years in the making. So the next time you're asked, just take a second to really think. What's in your medicine cabinet, and who knows about it? All right, let's jump right in. We're going to pull back the curtain on something most of us do without a second thought: taking medicine. But what's actually going on inside that tiny universe of your body? I mean, have you ever really stopped to think about it? You swallow this little tablet, and then, like magic, an hour later, your headache just vanishes, or your fever breaks. How in the world does that tiny pill know exactly where to go and what to do? Well, the second that pill hits your system, it's not a one-way street. It's actually a super dynamic, two-way conversation. It's a story with two main characters: the drug and, of course, your body. Now, in the world of science, these two sides have some big names: pharmacodynamics and pharmacokinetics. I know they sound complicated, but the idea is actually super simple. Think of it this way. Dynamics is the drug's action plan, what it's supposed to do. And kinetics, that's how your body reacts and processes the drug, kind of like a bouncer at a club deciding who gets in. We're going to break down both. So let's start with part 1, pharmacodynamics. This is all about the drug's mission. And to really get it, we're going to use a simple, but honestly perfect analogy. So here's the most important thing to get right off the bat. Drugs aren't magic. They can't just show up and give yourselves brand new superpowers. Nope. All they do is act like a director on a movie set, telling your cells to either speed something up or slow it way down. They're just modifying a job your cells already know how to do. So how did they pull that off? Well, it's almost always explained with this fantastic metaphor. Drugs bind to your body's receptors in a lock and key fashion. Just picture your body's cells being covered in millions of these tiny, very specific little locks. We call them receptors. And this just illustrates it perfectly. Over on the left, you've got the complex science. You can see how that drug molecule is shaped to fit right into the receptor. And on the right, the simple story we can all understand. A key sliding into a lock. The drug is the key, the receptor is the lock. It really is that specific. But of course, not all keys work the same way. First, you've got something called an agonist. This is like the perfect key for the lock. It slides in, it turns, the door opens, and boom, an action happens. This is the key that gets the job done. And then you've got the exact opposite, the antagonist. Now, this is like putting the wrong key in the lock and having it break off inside. It doesn't open the door, but now it's stuck in there, completely blocking the right key from ever getting in. It's a blocker. It stops an action from happening. Okay, so drugs are like keys. Got it. But this brings up a really interesting question. When we say a drug is strong, what do we actually mean? Are we talking about how much you need to take or how big of an effect it creates? Because, those are two totally different things. And this brings us to this classic matchup, potency versus efficacy. Potency is all about the amount of drug needed. So, a highly potent drug works at a very small dose. Efficacy, on the other hand, is all about the impact. What's the absolute biggest effect a drug can produce, no matter how much of it you take? Honestly, the best way to think about this is the beer versus whiskey analogy. Both of them can get you to the same maximum effect, right? That's their efficacy. But it takes a whole lot more beer to get the job done than whiskey. So in this case, the whiskey is way more potent. A smaller amount gives you the effect. Okay, so that's the drug's mission. But what about the other side of the story? Let's dive into part 2, pharmacokinetics. This is all about what your body does to the drug. And trust me, your body does not make it easy. See, every single drug has to run something called the ADME gauntlet. It's this 4-stage obstacle course your body sets up. First is absorption, just getting into the bloodstream. Then distribution, traveling to the right spot. Next up, metabolism, where your liver starts breaking it down. And finally, excretion, getting it out of your system. For now, let's just zoom in on that very first and maybe most important hurdle, absorption. This is basically the drug's attempt to get past the bouncer and into the club. That club being your bloodstream, where it can finally start to do its job. And getting past that bouncer depends on a few things. Size matters. The smaller the molecule, the easier it is to slip by. It also really helps if it's lipid soluble, which is just a fancy way of saying fat soluble. Why? Because our cell membranes are made of fat. And finally, having no electrical charge helps it pass through without any trouble. So we've got the drug's mission and the body's crazy obstacle course. What does all this science actually mean for you? Well, let's connect it all to something we've all seen before, a prescription pad. Take a look at this prescription for lorazepam for anxiety. See that instruction that says to be taken orally prior to dental appointment? That's not just a friendly suggestion. That's pure pharmacokinetics. The doctor is perfectly timing the drug's absorption so it kicks in right when the patient needs it most. Now, what about this one for Vicodin? That number, hydrocodone 7.5 milligrams. That's not random. That's a pharmacodynamics instruction. It's all about potency. The doctor has calculated the exact tiny amount needed to get the pain-relieving effect. It's science in a sentence. This brings us to one last, really crucial question. If we're dealing with such precise doses, how do doctors know the difference between a dose that helps and a dose that harms? Well, they have a special tool for that, and it's a number called the therapeutic index, or TI. Generally speaking, a safe drug has a therapeutic index of 10 or more. So what does that number actually mean? It means you'd have to take at least 10 times the effective dose to get to a toxic level. That's a massive safety buffer, a lot of wiggle room. But now look at this. A drug with a TI of 2.5 is a whole different ballgame. The toxic dose is only 2.5 times the effective dose. That line between helping and harming is incredibly thin. And this is why doctors are so precise with certain medications. There's almost no margin for error. So when you put it all together, from that initial lock and key moment to the body's intense internal obstacle course, the story of a single pill is just way more incredible than we ever imagined. It really is this beautiful, intricate dance between chemistry and biology. So the next time you pick up a medicine bottle and read, "Take with food" or "Take every 8 hours," you'll know it's not just a suggestion. It's a carefully choreographed step in that dance, all designed to make sure the medicine works perfectly.
Makes you wonder, what will you think about the next time you read those instructions?